let's get 2 minutes on the clock for your next question. 2 minutes and your time starts now. Isabella Harrington, a 28-year-old woman of English descent, presents to your GP clinic with complaints of persistent fatigue and dizziness for the past 3 months. She mentions having unusual cravings for non-food substances such as chalk, paper and ice. She denies any chest pain, shortness of breath, palpitations or weight loss. She doesn't smoke, drink alcohol or use recreational drugs. Isabella works as an accountant and lives alone. On examination, Isabella appears pale and tired. Her vital signs include a temperature of 36.8 degrees, blood pressure of 110/70, a pulse of 88, and a respiratory rate of 16, with a BMI of 22.5. Her cardiovascular, respiratory, and abdominal examinations are unremarkable. Question 2.1. What additional aspects of history are important to elicit to confirm Isabella's most likely diagnosis? Write 5 specific aspects of history. Alright, time is up. Let's have a look at those answers. So, additional aspects that haven't been covered here is going to be what are her dietary habits or what's her nutritional intake? Are there other aspects of her diet that we need to be exploring as well? Is there any personal history of anemia or iron deficiency or blood disorders? Now again, you wouldn't be having slashes in these kinds of answers. These will all be things that be tied up together. Is there any previous history of picker? Is there any previous developmental history, anything that occurred to her during childhood? Any history of gastrointestinal symptoms? Now that's intentionally quite vague. I think if you were to put some examples in there, that would kind of hone into that same thing and there'd be grouping associated with that. What is her sexual activity history or pregnancy history? Is there any chance she may in fact be pregnant? What is her menstrual history as well? Does she have any psychological or psychiatric history? This is a bit of an unusual behaviour you'd be wanting to explore. And is there any exposure history or environmental history, in particular lead exposure potential? We'll talk a bit more about that coming up. Is there any other detailed history of cravings? And again, providing potential things such as the duration of these cravings, the intensity. She's already mentioned some of these substances there, so to be honest, I don't think you would actually get additional marks for that. But again, kind of clarifying some of those cravings there would be worth additional marks. And tying into this as well would be the family history of anemia or iron deficiency or other blood disorders. Coming in from the chat here, we've got Melina, excellent, so coming into those GI kind of symptoms, menorrhagia, so part of that menstrual history, pruritus ani, yes, I know what you're getting at there. I would be saying again, potentially diversify with the Melina. You're ticking the box for the GI things, and there's other things you could potentially explore. Having said that, with what you're getting at, you might still get a half mark there. Vegetarian diet, so yep, you're looking at nutrients going in, and use of pantoprazole, fantastic. Again, exploring that absorption ability, or is something impairing the absorption, so well done. Also coming in from chat, we have dietary intake of iron, fantastic. It's almost like you guys know what's going on here. Oh, menorrhagia, again, yes, going into the periods there, past history of iron deficiency, well done, and family history of bleeding disorders. Guys, you are knocking it out of the park. Okay, I'm going to have to make harder questions, I think. Of course, what could be going on? It's a mystery. So let's get 2 minutes on the clock, and your time starts now. Question 2.2. What initial investigations would be important to investigate this condition? Write 3 specific investigations. All right, time is up. Let's have a look at some answers here. So, some of the big ticket items I really want you to be focusing in on here is going to be your full blood count and your serum iron studies. Because, as you've certainly picked up already, this is a case of picker, and one of the leading causes of picker is iron deficiency, and in particular, iron deficiency anemia. So, you'd be needing to confirm that with your FBE and your iron studies there. Now, of course, with all these things ingested, it's common to have electrolyte imbalance or organ damage, so you'd be wanting to keep an eye on urea and electrolytes, keep an eye on the kidney function. Tying into that, what's causing potential absorption issues here, you would consider doing celiac serology, and, of course, serum calcium or magnesium or phosphate levels, again, using those absorption markers to see is there issues in terms of the bowel's ability to absorb nutrients there. And serum lead concentration. So, in houses that have, lead paint or potential for lead to be around the place, it's actually quite common, sadly, for people with picker to be ingesting things that contain lead without realising it. And so there's a strong recommendation for people with these cravings for non-food items to have this assessed, particularly if they are in older type houses, because it is something that can cause profound morbidity. So one of those things you're just strongly encouraged to screen for. Let's have a look at what's coming from chat here. So we've got full blood count. Yep, fantastic. Again, I'm going to be mean. Spell it out. I know I'm being nitpicky. Iron studies, fantastic. And ultrasound pelvis. Don't know if you get marks for that one, but I think if you're worried about bleeding or not sure. Always good to throw something out, and I'd rather you throw something in than leave a potential spot blank. Coming in from Jenna here, we've got the FBE, fantastic, iron studies, fantastic, and celiac serology, fantastic. So knocking it out of the park, well done. All right, we have one final question on this case. So let's get 2 minutes on the clock, and your time starts now. Question 2.3. What is your management for Isabella's condition? Provide 5 management options. Doses are not required. Investigations return to show a serum iron of 30 mics per deciliter, normal range of 60 to 170, a serum ferritin of 8 with a normal range of 15 to 150, a total iron binding capacity of 450 with a normal range of 240 to 450, a transferrin of 360 with a normal range of 200 to 350, and a transferrin saturation of 6% with a normal range of 20 to 50%. Other results are all within normal ranges. All right, time is up. Let's have a look at some answers here. So, management options here. Obviously, we have a case of iron deficiency, and so we'd be commencing an iron supplementation. I think the numbers here aren't horrific. You could consider an oral solution here, or tablet, or solution. Of course, given the severity of symptoms here with the abnormal eating pattern, I think it'd be pretty fair game to be considering an infusion here, even though it doesn't specify the anemia component. I think given the impact and potential harm of the symptoms ongoing, an iron infusion would be pretty appropriate. Of course, you're going to discourage the eating of non-food items. You're going to monitor for sources of blood loss in case there is a bleeding pattern that's been masked for some time. You're going to be considering a referral to a psychologist for things like cognitive behavioural therapy to explore and potentially change the eating patterns. It may be the anemia is a bit of a red herring, particularly given there's no evidence of, the iron deficiency is a red herring, given there's no evidence of anemia there. Because this can be a psychiatric condition as well, so referral to a psychiatrist for diagnostic assessment could also be considered. Now, of course, we've addressed that there could be issues with the absorption, and we know that there is low iron. We'd be potentially referring to a dietitian for a dietary review or modification plan to make sure she's actually getting adequate dietary iron, and a plan to review iron stores in 6 weeks' time. Here's one of those times as well you could actually provide written information on picker/iron deficiency covering those things. It's kind of one of those vague management options there. It would be really a kind of last-ditch effort. I would be definitely prioritising these other issues here. So, having a look through what's coming in from the chat here, we've got iron infusion, i.e. Ferinject, fantastic. Oral iron supplementation, i.e. Ferrograd C. I don't know if I'd be doing both simultaneously. I'd probably list one or the other. You're probably going to get some grouping issues there. Increased dietary intake of iron. Again, yes, I think that would be good. You're addressing it from the dietary point of view, but you're probably going to be grouping there with referral to dietitian to optimize iron intake. From Demir here, we've got the Ferinject, fantastic. Multifer, again, kind of fits into that same kind of supplementation risk. 1 steak per day, dietary, fantastic. No milk with iron-rich foods. Oh, man, massive, massive, massive. And while that is a dietary thing, I think there is a chance you probably would actually get a mark for that given its specific dietary advice. Maybe not. I think it's probably a little bit risky. Likewise, referral to dietitian for dietary intervention kind of falls in that same category. So trying to diversify answers, I'd just be a little bit careful. Comment here, CBT, give me a break, man. Yeah, I know. You may think what a load of, but this could be a psychological condition, and so actually addressing it to redirect those cravings is actually a valid and used tool in this space. So, sorry, gets your marks, and is something that some patients do find very, very helpful.